Welcome to the July Roundup of ecancer. I'm Gordon McVie and I'm the editor. Busy few weeks for the video team. They've been enjoying the sun in Madrid and Barcelona and in Paris. The three important meetings that we've covered have been the EHA, that's the European Hematological Association, and that was absolutely chock-a-block with the new antibodies which are quietly moving cytotoxic drugs to one side in the treatment of myeloma and a number of other hematological malignancies. Then the meeting in Barcelona, just up the road, was an ESMO meeting concentrating on gastrointestinal cancers. There's not so much progress, but it turns out that some of the immuno-oncology drugs are beginning to show some promise in tough nuts to crack, like colorectal cancer and gastric cancer. And then in Paris, the WIN meeting, which is a transatlantic collaboration looking to accelerate the progress of promising new molecules into the clinic in phase 1 and phase 2 trials. And to pick up the EHA topic, we're very happy to announce another collaborative teaching module with SIOG, that's the Society of International Oncological Geriatric Oncology. And this is about CLL. And CLL, of course, is a classic smouldering, long-term illness of older people. And this is a module on how to manage chronic lymphocytic leukemia in this day of the new antibodies and the new non-cytotoxic drugs, all of which have been paraded at Madrid in the EHA. I'm happy to say that if you complete this module on CLL in geriatric patients, you'll be awarded 1 CME point. We have in the July issue of ecancer a couple of really important papers. I think, frankly, it's my passion for developing countries' oncology problems. I think that the outstanding one is from probably the expert in the world, having served for 20 or 30 years at IARC, and developed and published the manual, the encyclopedia of cancer incidence in 5 continents, with a lot of accent on the developing countries. Notoriously difficult to do this because of the lack of cancer registries, and this is the point that Max Parkin, the principal author and expert, has made in the paper. His co-author is Christina Stephan, who's this year's president of the EORTIC, which is the African Organization for Research and Treatment in Cancer, and she works with the Medical Research Council in South Africa. So a very powerful team. And they're presenting the results of cancer registries in 16 sub-Saharan African countries. And they put in all the caveats about incomplete data and so on. And you know, some of the reviewers thought this was a weakness. But I don't think it's a weakness, because all this data needs to get out and needs to be looked at across the world. Many lessons to be learned in Africa. And the authors highlight the fact that there are differences between the African data and the rest of the world, if you like, but particularly the non-developing countries, so-called developed. One would expect to see low incidence rates of cancers compared to, say, Western Europe, if the pessimists are correct and say the data collection is inadequate and you're missing data. The incidence of leukemias and brain tumours is indeed lower in those 16 cancer registries than in Western Europe or further afield. However, what is really interesting is that there is a marked increase in the incidence of certain cancers, particularly those related to infections. Those would be lymphomas, Hodgkin's lymphoma, the Epstein-Barr virus-related cancers, Kaposi sarcoma, hepatocellular carcinoma, and, interestingly, 2 embryonal-associated cancers, retinoblastoma and nephroblastoma. So very important data, I believe, for Africa, and it's also important for authorities who are trying to help bring better and quicker diagnosis of children's cancer in sub-Saharan Africa, and better and more appropriate treatment modalities. One of those embryonal cancers is retinoblastoma, and this month we happen to have a paper from another developing country, from Costa Rica. And this is from Jenny Chen and her colleagues in San Jose, and they have reported on follow-up and progress of 32 patients, young patients, pediatric patients with retinoblastoma. She comments, and her colleagues, that there are a variety of ways of treating retinoblastoma, and they include cytotoxic drugs and radiation therapy in an attempt to spare the eye, in other words, enucleation. And they report 2 cases of late cancer, which is a very serious late effect in children treated. And one of these children had retinoblastoma treated by cytotoxic drugs, and the other had the eye radiated. So very important that you can get this long-term data from a country like Costa Rica. Very important indeed. So from sub-Saharan Africa to Costa Rica on the way to Iran. And here we have a very interesting paper from Shavan and his colleagues. And they're talking about gene therapy. They've written a review for ecancer about the new ways of targeting gene therapy and making it meaningful. And they're particularly interested by hypoxia and hypoxia-related gene control. And they outline a number of ways of interceding a transgene into a hypoxia-promoting sequence. And although they haven't got any clinical data yet, their preclinical work that they're reviewing is really very important. Obviously, gene therapy has been around a long time, and obviously we don't have any revolutionary results yet. But it looks as if this new approach, looking at hypoxia, which is a common problem, especially in bigger cancers, might be another route in for carrying specific cancer gene antagonists. And then the last paper is from Dennis Horgan, and he's the director of the European Alliance for Personalised Medicine. I have a conflict to declare because I'm the chairman, and he gives me a plug somewhere in the editorial, and he's talking about the importance of making doctors, patients, politicians, public health doctors aware of the revolution leading to personalising medicine. It's clear for anybody who reads the daily newspapers that we have a whole host of new targeted drugs at our disposal now. They're not all cytotoxic. Many of them are antibodies, and therefore much less toxic. And Dennis Horgan is highlighting the fact, first of all, that there's general ignorance throughout all of those populations I named about the possible benefits for patients with the development of personalised medicine. But he's also highlighting, and it's not just for cancer but for all conditions, the hurdles which have already emerged through the bureaucratic mechanisms. He's concentrating on Europe, but it's not any different in the United States or in China or in Japan. There is a feeling that we are sitting with a whole box full of potential targeting molecules, and we can't get them out of the box and into the patient quickly enough. There are endless hurdles. There are arguments about restrictions and data security. There are problems about deciding what the best controlled clinical trials should be and what the accompanying diagnostic should be. Whereas the logic of personalised medicine, where you have a target within a cell, like hypoxia, which I've just mentioned, and you've got a way of deciding which patients are the most likely to respond. And indeed, in this situation, nearly always you find a response rate which is double or treble what you would have done if you'd tried the new drug without that diagnostic in the general population. The logic is that that's probably good enough in terms of getting the first steps through the regulators and the understanding that you're sitting here on potentially groundbreaking, if not breakthrough, approach to treatment. It happens that because in cancer we've had vast amounts of money spent on cancer research, much of it's been useless, but much of it lately has been very positive. And so there's more to talk about in the oncology field in terms of personalised medicine, but Dennis Horgan's group represents and illustrates steps forward in rheumatoid arthritis and in cardiovascular disease and in Alzheimer's disease. The general approach to narrow down for a specific patient who's got a specific genome, which we can now completely dissect all thousands of genes within an afternoon for under €200, that this is going to actually sharpen up the focus of treatment and make it more person-oriented, thus cutting down side effects and improving quality of life for patients. We've linked the editorial to a video which is illustrating some of the problems in terms of getting new drugs accepted by the regulating bodies when they're added on to existing drugs, so-called add-on therapy. And I'd recommend the video to you and the editorial. Thanks very much.